Good morning, everybody. It's nice to see a nice and full hall uh, for this group presentation. I welcome all my fellow speakers and the audience. This is an important topic for a cornea specialist for epithelial disease management, which we will cover several aspects of it. And it's one of the most difficult tissues to heal. I have no financial interest. What is the definition of a persistent epithelial defect, which has not started healing or showing the expected time of healing within 48 hours, and it's not completed by 14 days? It's still there. So, what would be the causes? It could be defective epithelial adhesion to the basement membrane, an abnormal basement membrane itself, a matrix metalloproteases overproduction, disruption of migration of regenerating cells. The association conditions could be recurrent corneal erosions, which we'll be covering, basement membrane dystrophies, BSKs, bullous keratopathy, Salzmann's degeneration. It could be limbal stem cell deficiency due to chemical injury or trauma or other causes. Overactivity of inflammatory markers, proliferation and migration of regenerative epithelial cells, stromal remodeling and melting can occur. The associated conditions are autoimmune diseases, KCS, Sjogren's, PUK, Murren's ulcer, SJS, and graft versus host disease. Neurotrophic causes like disruption of corneal innervation, we'll be hearing about neurotization later. Associated conditions like diabetes, hepatic keratitis, anesthetic abuse, severe dry eye, post-traumatic nerve damage. Surface trauma where the cell loss exceeds the regeneration capacity of the epithelial stem cells. Associated conditions like entropion, ectropion, lag of thalamus, trachoma, dry eye, corneal injury due to chemical or thermal burns. Hereditary conditions like deficient limbal stem cells, abnormal basement membrane, associated conditions like aniridia, epithelial and basement membrane dystrophies. The role of the basement membrane is extremely important, and so are its components like lamina lucida, densa, and then the anchoring filament and the fibril, which goes through the Bowman's layer into the stromal layer. It takes 6 weeks to regenerate after injury. The epithelium adheres poorly over the underlying stroma except at the leading edge. Sorry for the typo. Epithelium adheres well over the intact basement membrane within 6 days, and the adherence is due to the presence of hemidesmosomes. The absence or discontinuity is seen in recurrent erosion syndrome, which we'll be covering later. Role of basement membrane. The erosions of the basement membrane may be with the use of caustic scrubs. Basement membrane dystrophies show multilamination or absence of basement membrane. Shield ulcers an erosional phenomenon due to rubbing of the papilla and mast cell degranulation. This is a picture of DDLD. You can see Dr. Paras. Evaluation of a PED. A comprehensive history comprising duration, mechanism of trauma, prior treatment received, prior surgeries, associated ocular and systemic comorbidities, family history, immune status will help to arrive at an etiological diagnosis and allow more specific treatment. So, what is the treatment of PED? It is a step by step approach used to manage the PED. So, one should know the etiology. It could be a conservative treatment, progress to more aggressive options if refractory. First and most crucial step is determining the potential etiological factor. Next, the underlying condition must be targeted for local treatment to be effective, like nerve growth factor for neurotrophic keratopathy, metabolic control in diabetic keratopathy, medication withdrawal in iatrogenic causes, and LS limbal stem cell transplant for limbal stem cell deficiency. Preservatives like benzalkonium chloride, they prevent the advancing layer and prevent the migration of the advancing layer and loss of tight adherence, and it causes peeling back of the advancing layer. The topical anesthetics, if misused, can disrupt actin assembly within the epithelium. First step, stop all topical medications. Use preservative-free lubricants, punctal cautery and punctal plugs, but not in the situation where there is ocular inflammation. Band-aid soft contact lenses help to protect the damaged epithelium from erosion by preventing eyelid blinking and thus aiding re-epithelialization. Broad-spectrum antibiotics can be used over the bandage contact lens along with preservative-free tears. Temporary closure of the eyelid when the exposure is brief, but temporary or permanent tarsorrhaphy when there is log ophthalmos, like in 7th nerve palsy, or in neurotrophic ulcers. The non-exposure type defects can be managed by bandage contact lenses. Oral tetracyclines are beneficial due to their anti-collagenase activity. which inhibits matrix metalloproteases from inflammatory mediators and promotes healing. Vitamin C can be useful in promoting collagen building. Use of topical steroids is a two-edged sword. It limits the inflammatory response by decreasing recruitment of inflammatory cells. Excessive use of long periods inhibits cell migration, inhibits stromal wound healing. They are effective in PEDs caused by herpetic keratitis, SJS, atopic keratoconjunctivitis, Sjogren's syndrome, and graft versus host disease. Topical drops like sodium citrate, it can be used. There are Vacutainers available with blue lids in which you can put zero point 0.8 ml of distilled water and use about 10 inversions. You get about 0.8 ml there. And you can use multiple Vacutainers. It prevents accumulation, phagocytosis, subsequent release of degradative enzymes and oxygen-free radicals from polymorphonuclear leukocytes. As we know, PMNs are responsible for releasing collagenases and elastases, which can cause stromal melt. So here is a case which we had, not of a PED, but thinning with fungal keratitis. And that time we had topical sodium citrate available from Java Pharmaceuticals, no financial interest. They were just experimenting with it, and we didn't need even to use glue BCL to heal them and to prevent melting. Autologous serum drops can be prepared by centrifuging the patient's serum, diluting it in concentrations of 20, 50, and even 100%. But you cannot use it when the status of the patient has a lot of cytokines in their blood or if they have any systemic autoimmune disorders. Role in PED healing is attributed to several serum constituents that contribute to multiple steps in the healing process, like vitamin A, E, epidermal growth factor, platelet-derived growth factor, TGF-beta, nerve growth factor, insulin-like growth factor. Here I should mention that insulin eye drops have also been recently used to heal persistent epithelial defect. We had also used it in 2 to 3 cases with some success. Surgical management, debriding of the unhealthy epithelium, temporary tarsorrhaphy, amniotic membrane transplant, which is a scaffold for re-epithelialization and has anti-inflammatory properties and decreases vascularization and scarring. Limbal stem cell deficiency management with SLET when it's unilateral, and when there is bilateral, you may tend to use living-related or auto-SLET. Neurotization we'll be discussing in this GP, which is a new surgical technique for treating neurotrophic keratopathy and helps to restore corneal nerve sensation. PROS lenses, a new scleral contact lens known as prosthetic replacement of ocular surface ecosystem, has also shown promising result. Newer therapies like insulin-derived growth factor, human growth hormone, albumin drops, amniotic membrane extracts, matrix regenerating agent, recombinant human nerve growth factor known as Synergermin ophthalmic or Oxervate, which is the company name, has also been used and is in the market but not in India. Thank you for your attention.